Hello friends, so this is Neha and our topic for today is endotracheal intubation. So when we talk about endotracheal intubation, you should know it means the placement of a special tube in the trachea. Now endo means inside and tracheal means inside the trachea. So these tubes can be inserted through the mouth or through the nose. Now you must be wondering, why did I say that it can be inserted through the mouth or the nose. Now there are times when the surgeon has to operate on the oral cavity. So when there are surgeries which are needed to be done inside the oral cavity, you cannot have an oral intubation because the surgeon needs to view inside the mouth. So during that time, what they do is they insert the endotracheal tube through the nasal cavity, and this part of the tube is connected to the ventilator, so the anesthetist can manage the ventilation from that side and the surgeon can operate on the mouth. Okay, even in cases where the thyroid gland thyroidectomy and all has to be done, there are times when the anesthetist might prefer using the nasal intubation. So that is about the types of endotracheal intubation. So there is oral intubation and there is nasal intubation. Now you must be wondering, what are the indications that are required for an endotracheal intubation, or when do you say that a patient needs an endotracheal intubation? So it is to secure airway. So if the patient has collapsed and is not breathing, has stopped breathing, that's the time when he's going to need artificial ventilation, so to secure airway, to supply oxygen. So when you stop breathing, obviously there is no oxygen reaching your vital organs. So to supply oxygen, you need to do an endotracheal intubation. When there is a surgery where they're going to use general anesthesia, so when in such cases they're going to use endotracheal intubation. Ventilator therapy in ICU, when the patient is in the ICU and is in a critical state where he's either in coma or he is in a case where he's not able to breathe on his own. Okay, there is no spontaneous breathing that is taking place. In such cases, the patient may need to be intubated and connected to the ventilator. Even patients post surgery, like after the surgery, during the surgery also, and after the surgery. So not all patients come from the theater extubated. So some patients will come with the endotracheal tube to the ICU, and then after the anesthetist uh, looks after the patient and sees that all the vital organs are fine and the ABG results are normal, within normal limits, that's the time when he decides to extubate the patient. So you will have patients with endotracheal intubation in the ICU. Then cardiopulmonary resuscitation, like I told you, when the patient collapses and they give a CPR, that's the time when the patient might require an endotracheal intubation. Then there is equipments that are needed during an endotracheal intubation. So it is very important for us to keep all these things ready when we need to go for an endotracheal intubation. So there are different sizes. So I've mentioned for the adults. So the sizes that endotracheal tubes sizes that are used for adult patients are 7.5 usually used for females because of the stature that the females have. 8.5 because usually heavy built males can even go up to 9 mm. So there is 8.5 and 9 also. So usually most preferably numbers are, for male is 8 and 8.5 and for females it is 7 and 7.5. Now oxygen tubing with ambu bag and mask. So this oxygen tubing, there is a small connection at the ambu bag which is connected to the oxygen flow, and this is connected to the ambu bag so that there is continuous supply of oxygen when you are ambuing the patient. Now most of us are should be aware of the full form of AMBU. That's why I've mentioned it. It's artificial manual breathing unit. So AMBU and a mask. Mask is, again, it differs to the size of the patient, the face of the patient. So you should have at least two to three different sizes of masks which are available. And then you have the laryngoscope with blades. So usually patients, the anesthetists prefer curved blades. Laryngoscope have straight blades also, but most of the times curved blades are used. Then there is something called as Magel's forceps and a bougie. Okay, so there are two different things. I've put the pictures later on so you can have a look at it. And we'll specifically look at each function of the equipments. Then a stethoscope, a syringe which we'll need to inflate the cuff. Okay, so there is a cuff close to the endotracheal tube. Suction, which is the most important equipment during an endotracheal intubation. That is because when you're trying to intubate a patient, there is a lot of chance that there will be secretions in the oral cavity. Okay, so if the oral cavity is filled with secretions, the anesthetist is not going to be able to view the vocal cords clearly. That's the reason he will ask for a suction. So your suction and a suction catheter is at the highest priority when you are standing for an endotracheal intubation. And finally, the adhesive to secure the endotracheal tube in place. You can also have uh, xylocaine spray or xylocaine jelly. That is so that we can help the anesthetize the vocal cords or the oral cavity so that there is less trauma to the vocal cords. Out all the secretions so that you can have a clear view of the vocal cords. Another important point in endotracheal intubation is the position of the patient or the head neck position. Now what you see over here is a head. The head is tilted downwards. Okay, so hyperextension of the head, and you see that the neck is also hyperextended, the chin is lifted up. Okay, and what you have to remember is there should be no pillow under the patient's head. Now over here you see if it's a supine position it becomes difficult. So there is the oral axis, the pharyngeal axis and the laryngeal axis. Now what happens is the pharyngeal axis and the laryngeal axis, they both come and they intersect at this place. That's the reason why you're not able to intubate well. Now when the head is elevated, now if you have a pillow under the head, again what you see is there is still an intersection of the uh, pharyngeal axis and the laryngeal axis, which might again be difficult for intubation. Now if the head is elevated and the neck is extending, this is usually called as the sniffing position. So you see there is absolutely no intersection between the pharyngeal axis and the laryngeal axis and the oral cavity. So it just you are able to view the trachea directly, the vocal cords, and the intubation becomes easier. So that's the reason why this position is preferred, or it is the highly recommended position. So head elevated and neck extending, which is also sniffing position. So now what you have to remember, or the points to remember from the nursing point of view, when you have a patient who is intubated or has an endotracheal tube, every time you go to take the over of the patient, what you have to do is you always check the pressure in the cuff. Okay, so you have to feel the cuff, and then if you feel that the pressure is less, you need to insert some amount of air into the cuff so that it remains inflated. Why do we check the cuff whether it's inflated, or if it's deflated? What could happen is if it's deflated, it shows that the cuff or the near the tip or near the Murphy's eye is deflated. and there is a chance that the endotracheal tube can get dislodged. Okay, so that's why you need to check the pressure in the cuff. Check the position of the cuff near the lips. So once the patient is intubated, there is a marking on the endotracheal tube which helps to identify at which level the endotracheal tube is inside the patient's uh, lungs. Okay, so if it is on 22 or 24, just at the lip, at the corner of the lip, you need to mark it and you need to write it down somewhere where the endotracheal tube is found near the lips, at which side. Bilateral auscultation of the chest. Now, what do you mean by bilateral auscultation of the chest? Now, when you intubate a patient or when an endotracheal intubation is done, what usually tends to happen is the endotracheal tube can slip into the right bronchus. Okay, so there is a chance that it can just move towards one side of the lung and only one lung can get inflated, but the other one remains collapsed. Okay, so that's the reason why when you go near the patient, you hold the stethoscope and you check bilateral auscultation, and you can feel or you can hear the lungs expanding on either side. Okay, then post intubation, always a chest x-ray is demanded by the ICU intensivist or the anesthetist. That is because they want to check the tip of the endotracheal tube where it lies, and it could be around 5 to 7 centimeters above the carina. Okay, and as per infection control, the endotracheal tube should be changed after 7 days. This is done by the anesthetist, so you have to be around, keep things ready. Okay, and if the adhesive is soiled, which can happen because of the secretions, when you're changing the adhesive, it is very important that you do it in the presence of a doctor, because there is a chance that the endotracheal tube can get dislodged. There are some complications that are there with endotracheal tubing, intubation. That is, bleeding can occur if it's a difficult intubation or a loose tooth, so there can be bleeding. Patients usually end up having a sore throat post extubation. There can be upper airway and nasal trauma depending on the type of intubation. Tooth avulsion, I already spoke about it. If there is a loose tooth, there is a chance that the tooth can get dislodged into the oral cavity. Laceration and hematoma of the vocal cords. So if it's a short neck, a previous oral surgery, and when you try to intubate the patient 3-4 times, there are chances there can be laceration and hematoma of the vocal cords. So thank you so much, and I hope I've been able to clear out most of the points that needs to be covered in endotracheal intubation. If you're new to my channel, you can subscribe. We'll have more practical as well as theoretical videos on nursing and nursing theories. So thank you for watching.